ladies and gentlemen. I hope that you enjoyed yesterday, first day and also evening. And today we have quite busy agenda for the whole day. And I would like to introduce my co-chair, Paul Gold from Brisbane in Australia. So he came over to present some of his research, and we will share now this session about new technologies. Atul Verma, who was principal investigator of a Pulse Select trial, could not come for personal reasons, so he sent his presentation in Zoom format. So we will present this now, and then we continue according to this schedule with live presentations. So can we start the presentation?
Hello, and I'm so sorry that I wasn't able to attend this year's Prague Rhythm Conference in person, but I really want to thank you for giving me the opportunity to talk about the Pulse Select system and why it's my PFA system of choice. These are my disclosures. So why am I confident in using Pulse Select as my PFA system of choice? Well, first of all, there is extensive basic and preclinical work that's been performed on the system for more than 10 years. There's excellent evidence of safety and efficacy. The catheter is specifically designed for PFA. It's a very simple workflow. I've done cases and it works very well. And there is still a lot of future available for the system in order to grow. So I'm not going to go through all of the preclinical work, but there is probably more preclinical publications on Pulse Select than there is for any other PFA system. And some of these studies were really landmark studies. First of all, we showed that PFA with this system does not cause any PV stenosis in a canine model. We also published this very important work looking at the fact that with increasing doses of PFA, it was possible to stun the phrenic nerve, but in all cases, the stunning was temporary, and for all of these animals, the phrenic nerve recovered within a few minutes or a few hours. We also showed in this very interesting aortic esophageal model that it was not possible to cause any esophageal injury with PFA in comparison to RF. We also showed that these lesions are not only contiguous, but even in highly trabeculated tissues, the field can actually penetrate into the trabeculations and create a very nice contiguous transmural lesion. Now, we also published this very important work, which showed for the first time how important contact was for creating a good PFA lesion. So you'll see at the top that when the catheter is in perfect contact, 0 millimeters, you get the deepest and most contiguous lesion. But once you start moving 2 millimeters away, you still get a lesion, but the quality is less. And once you start moving 4 millimeters away, clearly the lesion is not very good at all. So contact matters. And you can easily assess contact with the Pulse Select system, especially if you use ice. I mean, this is an example of a video recording of the system, in this case, sitting on the posterior wall, and you'll see how nicely that catheter sits even on the posterior wall. Now, there's been a lot of controversy as to whether contact force actually matters, and I'm just going to come out and say it. Contact force does not matter. Contact is important, but in this study, we showed that exhibiting more contact force on a catheter does not necessarily increase your lesion depth. And even the catheter technologies that say contact force is important, if you read the detail, their manuscripts, you'll see that it's actually not that important. And their R-squared values are very similar to ours. Now, what about lesion durability? Well, there have actually been 2 3-month remapping studies performed in humans to assess lesion durability with PulseSelect. One was published by Devi Nair and presented at APHRS 24, and she showed that per PV there was 98% persistent PV durable isolation per vein, and that there was persistent chronic isolation in 96% of the patients. We did another study out of Vilnius, and again, we showed similarly good results. We showed that at 3 months, there was 95% durable PV isolation according to the per vein, and per patient, 93% of the patients had durable PV isolation. Only one patient had one reconnection in one vein. Now, the PulsedAF pivotal study was the IDE approval study for the PulseSelect system. I was happy to be the principal investigator of this study. And one of the first things that struck me was how safe this system is. The primary safety event rate in each of the cohorts was less than 1%, 0.7%. Up to that time, this was one of the lowest adverse event rates ever reported for a catheter ablation system. Furthermore, if you look at the efficacy of PulseSelect is every bit as good as the efficacy of all of the other systems. So this is just a comparative efficacy. And you can see that, yeah, the PulsedAF bar looks a little bit lower, but you have to account for the fact that we also did very extensive monitoring to look for AF recurrences in the study. Effectively, if you look at this, there's statistically no difference between PulseSelect and any other PFA system. And in fact, when we took the PulsedAF patients and we simulated 3 different monitoring scenarios, the PulsedAF monitoring, the Inspire monitoring, and the Manifest monitoring strategies, you could see that we could change the success rate substantially just by simulating a different monitoring strategy. Now, is all PFA the same, particularly when it comes to hemolysis? And the answer is absolutely not. With the variable circle PFA system and the pentaspline PFA system, you can see that with 40 to 50 applications, which is a normal number of applications for these systems, you get plasma-free hemoglobin levels that are far in excess of the severe hemolysis threshold. And in contrast, when you look at the PulseSelect system, you can see that even with 128 applications, you still don't cross the severe hemolysis threshold. And on average, you only need about 32 to 60 applications to do all the veins and the posterior wall. So this tells you that you have at least a 2 to 3 times safety margin when it comes to hemolysis and PulseSelect. And here you can see PulseSelect in comparison to other systems, and you can see that its hemolysis profile is very, very favorable at 128 applications in comparison to only 20 to 29 applications with the FARAWAVE catheter. Now, why is hemolysis important? Well, of course, it can cause renal damage, and that's very, very important. But hemolysis also has other untoward effects. So you can get a great deal of platelet activation, which leads to a coagulopathy, which in turn can increase the chance of stroke. So it's very important that you use a system that doesn't cause a lot of hemolysis. Now, why is it that PulseSelect does not cause a lot of hemolysis? Well, all of the electrodes on the catheter are not activated at the same time. With each pulse, there is actually an alternation between the odd numbered electrodes and the even numbered electrodes. So at any given time, only half the electrodes are activated, and the amount of hemolysis is directly related to your catheter design and how much electrical field is being dumped into the bloodstream. So in this case, we're only exposing the blood to half of the electrodes. Now, why do we do that? Well, it turns out that if you alternate between odd and even electrodes, you can actually get more tissue depth for your lesion at the same amount of voltage. So not only does this have the benefit of minimizing hemolysis, but it also gives you deeper lesions. Now, heat is a fact of life with PFA. Yes, it's true that the mechanism of cell damage is non-thermal, but there's always a little bit of heat generated by every PFA system. And not every PFA system is the same when it comes to generating heat, just like every PFA system is not the same when it comes to hemolysis. So this is an example of the Galaxy medical system, and you can see that even 3 millimeters below the tissue surface, there is about a 5 or 6 degree rise in temperature when you deliver a PFA lesion. But it's very important to understand that there are pulse parameters that can be programmed to minimize this heating effect. So why does Pulse Select have such a good thermal profile? Well, first of all, you only have half the electrodes activated at any given time. But with any kind of PFA system, there is something called edge effect heating, because when you deliver an electrical field into an electrode, it naturally concentrates at the edges and you get edge effect heating, which can cause problems. But for the Pulse Select system, they actually tested many different edges to the electrode until they found just the perfect edge, rounded edge, to minimize and eliminate this edge effect heating. And that's why the thermal profile of the Pulse Select system is so favorable. And in contrast to other catheters where the splines can move and overlap, and you can start to get concentration of field, which in turn leads to heating and microbubble formation, the electrodes on Pulse Select are fixed and they cannot be changed. So you never get overlap in the electrical fields. Now, microbubble formation happens more with certain PFA systems than other PFA systems. And what are microbubbles created by? Well, in most PFA systems, they're created by heat. So the more heat your PFA system creates, the more bubbles you're going to see. And I want to show you one example of the variable circle catheter. And if you look at the variable circle catheter, look how many microbubbles are produced by this system. It's huge. And it's because that variable circle is heating up a lot. That's why you get char. That's why we're seeing strokes with that particular system. In contrast, look at the Pulse Select system. We are now going to start delivering lesions. There's one. There's another one, and there are absolutely no visible microbubbles from the system. Those bubbles that you see up there are irrigation from the sheath. So there are big differences when it comes to thermal profile as well as heating. Now, a lot of people think that the Pulse Select catheter is just an old PVAC catheter. It's not. The catheter was completely gutted and redesigned. So the insides of the catheter are totally different with new wires, new insulation to make it the perfect delivery device for PFA. The connectors, everything was totally and utterly redesigned. The workflow of the system is also unbelievably fast and very simple. So you start off by placing the catheter at the ostium of the vein. You deliver and 4 times, and in between each delivery, you have to rotate the catheter by approximately 30 to 40 degrees. And that's because the catheter has a gap on one edge, and by rotating it 4 times, you can ensure that you have a nice ostial isolation. Then, using the deflectable catheter, you can move it superior, posterior, anterior, and inferior to the vein, and you end up with a very nice wide antral PV isolation. The FlexCath Contour is a brand new deflectable sheath that was designed by Medtronic specifically for the Pulse Select catheter. It's only 10 French, in contrast to a lot of other sheaths for PFA systems, which are very large and can therefore introduce a lot of air into the left atrium. This is a much smaller sheath. It's also a very well-designed sheath. So you can either drive the catheter with the sheath alone, but the catheter also is deflectable. So if you want to use the deflection of the catheter, you can use that as well. Now, some of the safety features, the system is R-wave gated so that you have synchronized delivery and it reduces the chance of any proarrhythmia. There's also something called the phrenic test nerve pulse. And what is that? Well, basically, if you are in close proximity to the phrenic nerve and you want to make sure you don't stun it, you can deliver the test pulse. And if you don't capture the phrenic nerve, you can be 100% sure that you can deliver in that location and you are going to get no phrenic nerve stunning, no phrenic nerve damage. But frankly, as we published before, even if you were to stun the phrenic nerve with this system, it always recovers within a few hours. Now, the question is, can you do any other area other than the pulmonary veins? And even though this is an over-the-wire system with a nose, the array is actually tilted forwards. So you can easily go on the posterior wall without causing any trauma to the posterior wall at all. And this catheter is actually sitting on the posterior wall. The vein is here, the catheter is here. And I'm just going to show you the final map from this case. This is the final map from the case. You can see that I completely isolated the pulmonary veins, the entire posterior wall. That was done on purpose, and it's very, very easy to do that. In fact, if you have a mapping system, what you can do is you can place shadows wherever you have been, and you can exactly see how well you have overlapped your lesions in order to ensure durable PV isolation, but also durable posterior wall isolation. So I've now done more than 100 clinical cases where I've done PVI plus posterior wall in all of the patients. On average, it takes about 50 to 60 applications. So remember, you don't even start to see severe hemolysis until 120 applications. So we are way below that limit, even though we're doing a lot of ablation. The dwell time is 32 minutes, and it only takes another 10 minutes for venous access and transeptal. So these are very quick cases, about 40 minutes. I use mapping and ice in all cases. My fluoro time is very, very low. And I just want to show you these preliminary blood test results. Look at the plasma-free hemoglobin. Yes, it's elevated because all systems cause hemolysis, but 403 milligrams per liter is a very small elevation in the plasma-free hemoglobin and does not reach the threshold of severe hemolysis. So I'm not prehydrating my patients. I'm not worried about hemolysis. I'm not worried about any renal damage in any of my patients. Now, does the system have room to grow in the future? Absolutely. So there is a new impedance-based contact force sensor that will be integrated into the catheter so you can see the contact on each and every one of the electrodes. And furthermore, the catheter is going to be fully integrated into the Affera mapping system. So you can map with the catheter, you can collect voltage, you can collect LAT. You can do anything you want with the Pulse Select catheter within Affera, and Affera can also track all of your lesions, tell you exactly where you've been. So at the end of the day, why am I confident in using Pulse Select? Well, there's been extensive basic and preclinical work, excellent clinical trial evidence of safety and efficacy. The catheter is specifically designed for PFA. It's a very simple workflow. I've done cases and it works really, really well. And the system still has room to grow and develop. Thank you very much for this opportunity, and I hope to be able to see you soon in person.
So we'll have time at the end for discussion. I'd like to introduce the next speaker, Massimo Grimaldi from Bury, and he's going to speak about Veripulse from Biosense Webster, and we'll also see him a little bit later on in a live case. Thank you very much, Massimo.
Thank you very much for introduction. I'm looking for, okay, I go by directly, this one. Thanks, Joseph, for this very kind invitation. I'm very happy to be here with you in this amazing meeting. Okay, can I have a pointer? No, okay. This was the first in vivo animal study. It was done in Atlanta with FDA just before moving to the first-in-man study.
Pointer?
No, this one. Okay, thank you.
Or is it pointer?
Perfect, thank you.
Yeah.
Okay. And these are the results. The results was very good because the nerves and arteries was perfectly saved from the energy, and also inflammation disappeared after a couple of weeks. The first weeks we had inflammation, but after 2-3 weeks the inflammation went away. And in all pigs the endothelium was completely healing after 1 month. So when compared to radiofrequency, the healing of endothelium is for sure faster. 2 findings, I think interesting. We find sometimes very, very small mineralization, and the calcium is important also for platelet activation, and very rare occurrence of multifocal denaturation of elastin and collagen. That means that we have some eating of the tissue. It is not zero eating. There were some eating, as in all PFA technology. Before and after ablation, you see wonderful lesions. We were very happy on these 10 pigs. Now, this is funny because we also did the posterior right atrium intercaval line, very large, wonderful. I remember that 1 pig at the last application was in sinus arrest, and we did a very good reanimation of the pig, and the anesthesiologist said, no, stop, we continue, and the pig was alive for just 1 month, because after 1 month he died because sacrificed. At the beginning this was wonderful because after 1 second everything was gone, no electrogram. We were happy, but this is not a good news because we lose our direction. We lose all potential after just 1 application. Really, we also had some vagal effect. Today, the catheter is this one, is a bidirectional catheter, and with a variable loop between 25 up to 35 millimeters, so we can cover every kind of pulmonary vein ostium. It is very important because we give 2 applications at the ostium and 2 applications just in the antrum. You need to rotate at least 30-40 degrees to be sure that you cover all the circumference, because where you have the gap, you can have a no good lesion, of course, between electrode number 1 and number 10. So you rotate and you give the lesion. Also in this study from the friend Tom, you can see that after first application, you completely lose the electrogram. In this case, 0 electrogram, also moving the catheter in the antrum or rotating. In this other case, very small electrogram. So we lose the electrogram. And this may be a trouble because when you have this situation, okay, the lesion is good because you have a good ostium, anatomical favorable ostium. But when you have an ostium with an elliptic shape of the ostium and the carina is very deep, is much more difficult to touch properly in this region. And so you lose the electrogram and you don't know that you didn't do a good job in this region. In this paper from Luigi Di Biase, It's very interesting to see that, of course, Atul also shown something similar. When you touch, the lesion is perfect, but in the places where you don't touch very well, the lesion is poor. In this situation, less than 1 gram, we are not touching. You see, the lesion is really poor. We are doing lesion only close to the first 2 electrodes. So the system helps us with the TPI, Tissue Proximity Index, that is an algorithm based on the impedance. And this algorithm tells us when we are touching or not the tissue, if we are in contact or not. And you can see that when we are touching, we have a better lesion, and the system tells us in the places where we were touching or not. Of course, when you do 2 ablation, you increase the size of the lesion. So the message is that you create a good lesion if you touch, and the TPI tell you if you are touching or not, and this is very important because also the tags say us where we did a good job and where not. And the repetition of ablation increase the size and the depth of our lesions. This is an example, very nice from Okumura, and you see right superior pulmonary vein, good TPI index, you see, good TPI, and very good lesions. Right inferior, not good percentage of TPI, and we have some gap in our isolation. The same for left superior pulmonary vein, the contact on the anterior shape was not perfect, and we had a gap. So I think that this index is very, very important because we lose completely the electrograms after the first application. This was the first MN study. The INSPIRE study was the European study, and was, I think, a very, very good and also lucky study because we had 0 adverse events. The procedure time in wave 2 was around 70 minutes. And the fluoroscopy was 7.8 minutes. Today, many centers do this procedure without fluoroscopy, zero fluoroscopy. And also the success rate was good, was 76% after, you see, 1 year. But was very, very good, the percentage of adverse events was 0. Also tamponade that is not related, of course, to the energy, was 0 adverse event. So the safety profile is perfect. About predictors of success, of course, patients with a normal heart, they go better, and also give more than 12 applications per vein, increase the success rate. So right now we give 6 applications in the vein at the ostium and 6 applications in the antrum. That means 12 applications. Every point gives 3 applications, one soon after the other one. It's a very easy approach. We tried in our center to do this procedure without intubation in deep sedation. And with this protocol, that with midazolam, ondansetron, and dexamethasone, the patient was very satisfied, was very happy about the anesthesiology part of the procedure. Of course, the colleague of anesthesiology was in the lab with us, but we did it in deep sedation. I think that the most important is this system, because this system is Massimo, SedLine with 1 S, not 2, like my name. This system is very nice, because with this algorithm based on electroencephalographic signals, tell us the depth of the sedation. It is between 0 and 100. And when you're close to 30, you are risking to need an intubation. So this is very good to have a perfect dosage of our anesthetics. This is the ADMIRE pivotal trial. This is the trial in the US. They had, the time of procedure was a little bit longer, and success rate is almost the same, little bit less, but they had some complications. They had 3 cardiac tamponade, but you know that tamponade is related to mechanical usage of catheters. And they also had some transient ischemic attack and 2 strokes. So, after the ADMIRE trial, the catheter was on the market, and there were some 3% of the stroke or ischemic transient attack, and so there was a warning. The warning from FDA was not a block of the catheter, but was related to instruction. This warning tell if you use the catheter with a lot of application and the same point, without waiting a little bit, you are creating some risk. And the warning tell to US physicians, please follow the instruction. Stay in the pulmonary veins and don't avoid to do too many applications in the same point. This is the crucial part. Why these stroke or ischemic events that are possible with any kind of technology? It is not related only to this technology. Because with radiofrequency, you increase the temperature, of course. But with pulsed field, we didn't expect any increase in temperature, but we have increase in temperature if we give many applications on the same point. Because the blood cool the surface, but the tissue has an increase in temperature with any kind of system. And we are studying, these are other systems, not Varipulse. You see here, you have 3 different systems that you know very well. This is Varipulse, Pulse Select, this is Affera. And we are studying also now with Varipulse. We are putting a transesophageal monitoring, not because we are afraid of the esophagus. The esophagus, the risk of esophagus, there is not. But we calculate the increase in temperature in the tissue between the electrode delivering radiofrequency and the esophagus. And when we are closer than 6 millimeters, we have increase in temperature, 6-7 millimeters. When we are far, you see this electrode number 1, nothing. Number 2 is closer, just 1 degree more. Number 3 is very close, it's 5.5 millimeters. You see an increase in temperature of 2 degrees. This is nothing for the esophagus, but it's telling us that there is a heating. And I did a study, very deep study with physics, because I'm a mathematics scientist. And now we are going to publish on, this is not a medical journal, this is a mathematical journal. This very complex formula that tell us which heating are we going to expect from any kind of catheter. This was done on the Varipulse, now we are studying with Varipulse. I don't understand this formula, it's too complex for me, but they are very clever people and they are physics, and so they are studying. And also, studying in the literature, I think this is very interesting. The pulsed field ablation is used to activate platelets. When you have a wound, you can use plasma, and you can activate the plasma to accelerate the healing of the wound. You can activate the plasma with thrombin. This is the most used way. But in some studies, instead of thrombin, they activate the platelet using pulsed field. With pulsed field, you activate platelet, you increase the level of growth factor, and you accelerate the healing of the wound. So we have to know that pulsed field is able to activate platelets. Just 1 minute for our experience. We do all procedure with any kind of technology. We take all the steps of our procedure because I need to understand also what my coworkers do and myself as well. And you see that the flow time is very low, just the time for transeptal, because we don't use intracardiac echo because the reimbursement in my region is very low. It's 3,900 euros, and we can't buy intracardiac echo. We don't have enough money to buy intracardiac. So we do transeptal using fluoroscopy. Mapping time, dwell time, ablation time procedure has a good time. And this is a mean of my coworkers. You see that the flow time is around, with PFA, around 5 minutes, 2.5 minutes, 3 minutes with the RF. And the dwell time is around 40 minutes. So I think the time is good, and with PFA is a little bit less than radio frequency. I'm also using Q-dot, especially for young electrophysiologists, because I think that PV ablation is very important for young electrophysiologists, and use a single tip catheter may be important to learn how to manipulate catheters in the left heart. And we are also doing now a study comparing, a randomized study, comparing PVI only versus PVI plus just posterior part of appendage. Because with this catheter, we can just select 6 electrodes and do a transmural lesion on the left lateral ridge. You know that the left lateral ridge may be more than 10, 12 millimeters. And the pulsed field ablation thickness is around 5, no more. It's deep, you don't go more. So I think that with the bilateral approach on a so important place for arrhythmogenesis may be important. Thank you for your attention.
Thank you so much, Massimo. We might take some questions now because you'll go later to the live case. So are there any questions from the audience? Massimo, I might just start. Can you use this catheter outside the veins?
Okay. You can. And the message in the US was it's better if you stay at the vein and you don't go out of the vein. So this was the message of FDA. But many, many centers use this catheter and also the other ones outside of the vein. I use it only on the vein because I don't have any evidence-based medicine that doing a posterior wall is better. And so I don't do, honestly. We are doing a study now. In this study with Atul Verna and many other centers, comparing PVI only plus PVI plus posterior wall or PV plus rotors. And this study is nice because when you have recurrences, you stay on the same approach. So at the end, we will see what is better. There is some study telling that posterior wall can add something in persistent atrial fibrillation, but the data are not so consistent. So right now, I'm not using because I want to keep the advantage of this technology. It is the safety, but the safety is guaranteed when you are there. If you do a lot of application, hemoglobin, have you seen, you can create some trouble.
Can you tell us a little bit more about the TPI, the contact index? What parameters do you look for in what's measured with that? TPI is an old index because we are looking at electrical coupling between electrodes and tissue since more time with a lot of technologies. And when you put a catheter in the left atrium, you should stay in the blood without touching the wall for some seconds, because this is important because the system studied the impedance of the blood. So then the system will compare the impedance in the blood with the impedance close to the tissue. And with this difference, give you the percentage of contact. So the TPI I think is very useful. Yeah, because also the tag, I see only the tag with a good TPI. And if the electrodes clash?
Yes, the system stops. It's protected.
Automatic.
It automatically stops because you have too high intensity and you have a short circuit between electrodes.
And it will warn you that...
yes, and you stop immediately and you can't deliver power.
That's excellent. Are there any other questions for Massimo? Thank you so much.
Thank you, Paul. Thank you so much.
Appreciate that. Thank you. We now will head to Homolka, transfer for Dr. Peter Nissel
to speak about the globe and cardium. Do we have contact?
Yeah, can you hear me, guys?
Ah, yes, yes.
Okay, very good. Okay, nice to meet you. Nice to see you and hear you. Okay,
Nice to hear you too.
Fantastic. Okay, so my aim this morning is like speaking about globe catheter, which is a single-shot map and ablate multi-electrode spherical array pulse field, but even the radio frequency ablation catheter, because this catheter is long time developed mainly for radio frequency and then switched to pulse field. On behalf of my older friends, Vivek Reddy, Honza Petru, Toshe, and Pavel Hala, Jan Škoda, all these guys were involved in the first event trial where we perform here in Prague. And actually, what is the globe technology about? Okay, so I was speaking mainly about pulse field, but then I will add some comments about radio frequency. So the globe is spherical, 30 millimeters array in diameter, adapted with 122 electrodes with plus minus the same area. And this catheter is designed for mapping, ablation. You can choose, you can pick up from all these like 122 elements, electrode you can paste, you can entrain the arrhythmia. So it's like very complex and very useful system for everything, mapping, ablation, and even pacing. So I will go through, okay? So this adapt with really like robust sheeting. Actually, when you prep all the things, because now for the first look, it looked like really massive, like very big one. But actually, if you consider after deployment, the catheter is in the full contact and actually is isolated the application. So the interface with the tissue is completely isolated. So you don't need, actually we hear this morning a lot about like hemolysis. So it's about application. So it's not volumetric application. If you compare like single shot or other like pentaspline catheters, other catheters, so the pulse is going elsewhere, okay? In globe catheter, it's going really like in balloon, right? So it's going really directly to the tissue. So you don't need to be actually afraid to apply like maximum energy while you have like issue with the hemolysis. So this is bipolar energy, and if you compare with other technology, as I said, so you have very elegant interface with the tissue. So why single shot? Because and I will explain later, if you are in the contact, speaking about PVI or in other tissue, other location, so you can pick up just the electrode, you are in the contact. So this is a deployment of the catheter, which is going transeptally, like for PVI mainly now. So under the fluoroscopy, the delivery of the catheter is really easy, but we are using eyes for this, okay? So delivery of the catheter is much better to control by eyes, not only by fluoro. Okay, so when the globe is open, okay, so all the arrays are open and widely connected to the contact. So then you can use just so-called like flow map, which is based on the thermal effect. So thermal effect means that the electrodes are able to detect the changes of temperature, and then based on that, you can visualize the area where you are no contact and contact. So actually speaking about PVI application, you can clearly see the ostium, antrum ostium, and then based on the contact of this flow, the first information, because this information is going immediately, okay? So then you you are switching to the contact map, and based on the contact map, then you pick exactly the elements you want to apply. So you want to get the pulse field there, okay? So briefly, the catheter, like this mapping principle, I think it's like speed up, so actually it's not real time, but you have some information about constructing the anatomy. Just one comment about anatomy. If you apply a lot of force, you can deviate the anatomy. So it's like, don't be too much afraid about what you have, because if you are pushing, you can deviate. But in principle, then you can see on the left side of the picture, then you have this flow map, you have egrams for the globe, and then after that, you can just pick up the points, which I show now. So the contact sensing, and actually on the middle picture, you can see all the electrodes in the contact. You can indicate on the map the orifice of all the veins. So you can really, based on anatomy, and I must say that even without eyes, you can practically manipulate with the catheter safely, and you even don't need too much fluoroscopy. So after getting the good contact around the orifice of the vein, then you are ready to get application. So this is the movie. You can I will show you briefly. So we have voltage map on the right superior pulmonary vein area, and then you pick up the points, okay? Now apply the pulsing, which takes like, actually you can choose like double pulse or single pulse, so actually not more than 25 seconds. And then after the pulsing, you have immediate information. I wouldn't like to stress too much about voltages, because we know that it could be stunning, and actually all this pulse field technology, you can show fantastic reduction of the voltage. So I wouldn't like to comment too much, because it's like not too much valuable information for me. So the first, I mentioned our first in-man trial, which is Pulse EU trial, a single center, 3-operator study, and we enrolled like 59 patients, and actually in these 2 groups, we tested like 3 different delivery systems, delivery energy systems, and delivery like strategy. And in the G4, we applied the most of the patients. The patient characteristics, actually, it's not about only proximal atrial fibrillation. In the first in man, we have like 40% of persistent atrial fibrillation, and after several cases, after like running patients, we then started to apply more and more posterior wall, even like mitral lines, and in the last scenario, in different study, we used even CTI. So dwell time and timing of the procedure is written here for all the group. The sum is here, but if you consider PVI only, delivery in the seconds is very elegant, like 42 in average, 42 seconds, and the procedure time, if you even consider to prep all this, fluid management and whatever. So we are around like 1 hour total time puncture, which is really. So whenever you deliver the catheter in the body, like in the left atrium or right atrium, then the procedure is going very fast, okay? And because, you have immediate contact, you can choose the electrodes, and then you apply immediately. So this is the left atrium after delivery. So you indicate the electrodes you apply, actually you deliver the pulse field, and then actually you immediately map. And actually, I didn't mention that you can get even activation map. So if you have some and we have several of these patients. We get just 80 running during the procedure. So then you can apply like activation map, and you can, based on activation map, you can just apply the just single electrode lesion if you want, okay? So the study, even the first immense study, was based on remapping principle. 2-3 months after the index procedure, we did all the maps, and we were carefully looking at extension or retraction of the lesion. So actually, we were very focused on the border zones of the system. Actually, we didn't see too much extension of the index procedure, post map, and then three months map was really comparable. When I have a recorded case this morning, so I really don't want to show you too much about the procedure, but actually I can switch to maybe a CTI, which is the latest development. So we add for some patients even CTI lesion, and then I must say that ice is very valuable. So for this, it's highly valuable. And so you can control the globe position, okay? And when you have the contact there on the CTI, then you can choose the double line, so you can really create the lines, not only like white area, because we are always considering the effect of to avoid AV node hitting AV node. So you all know how important it is, okay? So you can create the CTI as well. This is the CTI validation and after the application. And for sure, and we mentioned several aspects. So hemolysis is one aspect of a PFA application, and coronary spasm is one of these. And we know that if we apply like pulse field on this CTI area, so you can have like 90% of spasm, but subclinical or not clinical spasms. So actually our spasms are like really like less than 1% clinical. And you know that the prophylaxis for nitrates, we tested for all this technology. So for the globe application, we tested as well. And we really need to observe, and we need to get more information. So to be really safe in that respect. So my last slide for this globe technology is the results of the Pulsar IDE trial, which was presented by Vivek Reddy this 3 weeks ago during HRS. And this was really fantastic study. It was a multicentric study containing like 183 patients. We got follow-up on 162 patients, and look at the safety. The safety profile is excellent, okay? And if you have durability information, look at that. So it's like 95% of durable lesions in the veins, and the effectiveness 12 months after the treatment is 78%, which is indicating that it's very, very highly safe technology, and we need to consider how to adapt for the clinical practice. Okay, thank you for attention.
Thank you so much, Peter. Now that we have you, we might ask some questions, if that's okay.
Yeah,
Are there any
I'm waiting for the questions.
Oh, good. Are there any questions from the audience? Just to start, what fascinates me, this is really great data. It's a one-stop shop, this device. With the actual mapping and contact, that's fascinating. It's temperature-based. Can you explain a little bit more about that?
Actually, in the beginning of the first patients were done is with temperature monitoring in esophagus, and we validate how we accurate, how we are able to accurate measure the temperature change on the globe comparing with the indifferent electrode. So we got a very valuable information that so we can use the thermistor effect from the globe. So I think this contact, system was developed even in the first designing. So as I mentioned, this catheter was original RF catheter, and I didn't stress during, when I showed you the CTI application, that all the CTI application were done in radio frequency, with radio frequency.
Radio frequency.
To be a little bit safe in terms of the AV node, okay?
With the, have you ever had difficulty finding, say, the right inferior with the globe? And is it difficult? Is certain veins more difficult than others?
Actually, I think, well, it's not really, because, whenever you are there, you are there. So actually, a lot of times happen that, for example, in the left atrium, so a lot of times happen, you open the globe, immediately get voltages, immediately know the flow. So you immediately know what is what. So it's ostium, PVI, so, PV ostium. So I think that this is really fascinating. Actually, all the prep needs to be simplified. It's no doubt, okay? All the prep of the catheter, like, flushing, all the things should be much simpler.
How long does that take, the preparation?
It's like, maybe like 1/3 of the procedure.
A third of the procedure time.
Yeah.
Is
But
in
actually, because in my center, we are always like to be independent of companies. So we have all our technical suits and everybody. So actually, we really need to be independent of companies. So I really want to train them to be more simple. But when I show you, when you open the catheter, you put the catheter in the body, in the atrium, then the procedure is super fast. But it's not a question about super fast procedure. I think it is fast and safe and durable.
And flows.
I think there's 3 aspects, okay?
And how many applications to do the posterior wall?
Actually, well, usually we got like 4 sites only, okay? And because, if you are in good care, you can choose even you can, if I know, okay, sure, sorry. So if I know the patient is dedicated since the beginning for the posterior wall, I can get more points on the PVI. So even I have going for all individual veins, then I can expand the posterior aspect of the veins. So then I don't need too much on the posterior wall itself. So maybe I can just stay with 2 or 3 applications, sometimes 6, but it's max, okay?
That's good. So you can modify to decrease. That's excellent. Are there any other questions from the audience? Well, thank you so much, Peter. That was an excellent presentation. That's great data.
So much.
Really impressive. Thank you.
Thank you.
Next, we have Ante Anec from Split. So we'll connect with Split. And he is speaking on Cine Burst, Arga MedTech. And hopefully he's already here. Oh, excellent. Thanks so much.
Hello, everyone in Prague. Please confirm that you hear me loud and you see my presentation.
We hear you loud and clear and we can see you. So that's great, Ante. Welcome. And it's great to have you.
Thank you. Let me proceed. So hello to everyone from sunny Split. My task today, and I really try to be short on a lecture because I'm not able to be for you with a discussion since I'll be already in the case to show you the live case in an hour and a half or so. So I'll be quick with the lecture. So we talk about sine wave electroporation with Arga MedTech PFA platform. These are my disclosures. The Arga MedTech coherent sine burst electroporation system consists of a proprietary generator, arguably very versatile and very powerful machine, and proprietary catheter. The catheter itself is a quite floppy, very flexible 8-electrode structure. And you drive the shape of the catheter with stylet. So you don't exchange catheter when you ablate, you just exchange stellate. So here it is. So when catheter is when you insert the circular stellate, then the catheter goes circular, and you have a reasonably good tool to do the PVI. Of course, as any circular catheter, you're not covering 360 degrees, and then you have to move. We'll show that in a live case. After that, you can extract the circular, insert the linear stellate, and you get the regular bidirectional catheter with which you can do whatever you want. Here's the next story. Here's the next story. See how it looks on a fluoro. Sorry, guys. Stop here. You see how it looks on fluoro, because when you're circular, you're covering the 270 degrees of PV ostia, but it can be linear, and you can use all 8. You can just use part of the, let's say, back 4. You can just use 1, 2. We call it tip, and then it's true focal lesion. So it's very versatile, and you really drive it according to the needs. The catheter can deliver. That's the catheter side. On a generator side, you can change the way you deliver. You can deliver unipolar to get a deep lesion. You can deliver bipolar to get more width, or you can do what we call phasing, because when we do the phasing between deliveries, the system is changing between unipolar and bipolar to get best of the both products. So this is why you get the width like you're doing bipolar, you get that like doing unipolar. This is something unique. The BURST-AF clinical trial preliminary results. BURST-AF was the first in human clinical trial, typical early safety and feasibility trial. So far, this platform was tested in 4 centers. Again, the typical evaluation, early safety effectiveness in persistent and paroxysmal population. 12-month clinical follow-up, but a secret ingredient is a prospective invasive remap. These results on the first 90 patients that were prospectively remapped were published in Heart Rhythm and presented as a late breaker at a recent HRS. This is HRS. This is a list of BURST-AF investigators to whom I have to thank for the collaboration. The first 3 centers were here, and then recently the last 10 procedures were done by Team New Zealand. We had so far treated 100 patients in this journey, fair amount of persistent, otherwise typical AF population. And we didn't have PV stenosis. In 20 paroxysmal patients with pre and post MRI, adjudicated by the core lab, none had SC or SCL. There were no clinically apparent coronary spasm, and low-dose nitro were given as a pre-treatment. There were no phrenic damage, no phrenic neuroparalysis, no esophageal damage, no conduction disorders. However, in early batch of patients, because we're using high workload for high dose, we bumped to a severe adverse event. Unfortunately, it was hemolysis, and we induced acute renal insufficiency. Patient fully recovered but needed hemodialysis. After that, we significantly lowered the dose. 2 additional serious events were recorded, none of them connected really to the procedure. And this is a story. So when we bumped to this single serious adverse event in hemolysis in a cohort that otherwise had a very pleasing durability of the lesion set, we dramatically reduced the dose. We dramatically reduced the workflow, the number of applications per vein, and the dose per single application. And then we typically start to see some lesion regression or PV reconnection. And then we gradually increase the workflow, gradually improve the workflow of the dose, the PF dosing, and PF scheme. And finally, I'm going to focus on the last 43 patients that are treated, optimized workflow, optimized dose. And we had almost 99% of PVs durably isolated. Most of the posterior walls were isolated. And across the experience, we had fantastic 100% durable bidirectional block in CTI. Overall durability, including the rolling patients in single center, is more than 94%, which I found impressive. When we analyze our reconnections, we do have some predilection sites for reconnection. So anterior part of the right inferior and anterior part of the left inferior are predilection sites with this technology, and definitely you want to take care about these locations. When we compare the results of the ARGA system with other systems that were tested, you see that everybody and all the systems had initially less than ideal durability, but then with optimized, you get to this 90% plus zone of durably PV being isolated, which is impressive. And then no wonder when you have this fantastic durability. So imagine this, in paroxysmal population, this level of PV durability results in almost 95% of patients being AF-free, any kind of arrhythmia-free at 6 months. And for persistent population in 6 months, we had 90% success rate. Well, I'll conclude that it's really simple to do the procedure with this. The system is not seamlessly integrated with the mapping system. In a live case, we'll show you our best way how we integrate it. It's evaluated both in paroxysmal and persistent population. It seems to be very effective and efficient. The nominal dose, it takes 30 seconds to fire a PFA from 08 electrodes, let's say when you're doing PVI. So 30 seconds per application, 6 applications for left-sided veins is our workflow, 7 applications per right-sided vein. So it usually takes 18 minutes if you're in deep sedation, or 13 or 14 minutes if you're in GA, with 99% chance of durable PVI. And this single catheter solution can be very cost efficient. Again, 30 seconds per application, that means that you're doing the GA, it's around 2 minutes for application for PVI. The next step for this technology is an IDE trial, soon to be commenced in the next 2 months or so. And I'll just show you as a teaser what this technology can do on a ventricular end side, because this is the animal lab data. It's able to do very deep lesion, close to 21 millimeter depth, and staying quite narrow. Sometimes you don't want to have 30 millimeter lesion depth. If you in width, if you want that, that's configurable. You can do that. But I think it's nice to stay, especially for the idiopathic ventricular arrhythmias at night, to stay like this. With this, I conclude the lecture. I'm sorry that I couldn't give you experience in a full mode. However, I'm waiting for your questions.
Okay, thank you very much, Ante. It was very interesting data. So is there any question or comment? If I can start, if I understand correctly, you can use a different sort of stylet to change the shape of this catheter? Is that
yes.
right?
What comes out of the box is a single catheter with 8 electrodes and 2 stylets. One is a fixed circular stylet. We use it for PVI. And the next one is a linear stylet that has a mechanism for moving the catheter. So then you get steerability. So when you insert the linear stylet, you get steerable catheter, and you can choose where do you fire from. You want to fire from the tip of the catheter. You want to fire from the mid part. You fire from the back 4 section of the catheter. You want to fire all 8 in case, let's say, you have long roof line. This is what you can configure.
And
yes.
placement of this lasso inside the left atrium to different veins is done mainly by the sheath?
We use rotation of the catheter and the steerable sheath. Yes, we'll show it soon in a live case. We'll show you the PRAGUE isolation. We move, and with the good of this catheter, you're allowed to move because it's soft. You can allow to move both clockwise, but you can also use counterclockwise, which we really find very useful when you have this circular catheter. May I remind you that when you're moving the varipulse, you are not allowed to do this counterclockwise rotation. I think some of these tamponades that have been reported with the varipulse might have been that operators were not sticking to this rule.
So yeah, the other question is if you how you decide what kind of regime to use, like you said unipolar, bipolar, or mixed. How you decide which one to use?
So for the PVI, it's almost exclusively bipolar because we use a circular electrode, so we are blading in between the electrodes. If you have some, let's say, spot that you think it's hard to get, then you can switch to the focal. Let's say I'm having a hard time It was just one case. I have a hard time, and I'm not convinced that I delivered good lesions at the inferior septal aspect of the right inferior. I switch to a focal solution, and then I can choose unipolar or bipolar. With unipolar, you get more of the lesion depth. You can go and you do one, we call it, and then you can do the nominal dose, you can do max dose, which give you close to 10 millimeter depth. For the roof line, where we really want to transect the conduction across the septal pulmonary bundle, we tend to use either maximum output, which really gets us close to the 1 centimeter depth, or we can use phasing to get that more the width. So in a CTI, again, you're doing long linear lesion, and maybe you're doing some reinforcement with focal. Then you can start with the phasing to get also the wide strip of air tissue ablated across the CTI. It's really a matter of the workflow, of your preference, on what do you see on ice, especially if you're ablate with a, let's say, focal solution. So let's say 1-2, the tip of the catheter. Imagine easily that one day if I be ablating papillary muscle PVCs with this, I'll probably go in a bipolar, because if I'm well aligned with my pec muscle, I can choose where from, and I can go bipolar, or choose unipolar to go. It's really versatile, and it's up to operator.
Okay, thank you very much. Any other question? Yeah, if not, thanks, Ante, and we are looking forward to seeing your case in later during the live cases.
Bye-bye.
Okay. Now it's my pleasure to invite my co-chair, Paul Gold, and he will talk about another new technology, which is called Alepulse from Biotronic.
Thank you so much, Joseph, for the kind introduction, and thank you to Joseph, Peter, and Vivek for inviting me to this excellent meeting in an absolutely beautiful city. It's just a hop, skip, and a jump from Australia. No, not really. It's a long way, but it's very good. I'm very happy to be here. So just as a way of disclosure for me, I was the principal investigator in the RESET AF clinical study. We studied 36 patients, and I'll show some of a recorded case, and my colleague, Dr. Wahid Ahmed, assists me in the case. And the next speaker was also a principal investigator, Dr. Pierre Kwan, and Dr. Stuart Thomas was also a co-investigator at Westmead, and we thank them for their collaboration. So this is the novel system, the Alepulse PFA system, and I draw your attention to the bottom of the slide, the most novel part, which is the catheter. It's a double helix or double spiral in 3 dimensions. You can see the side and the end on view. There's 2 sizes. There's a 25 millimeter and a 30 millimeter. And in the case, we use the 30 millimeter. There's 16 pulse field ablation electrodes on the catheter, and they're activated simultaneously. It's bipolar, biphasic, and it gives a field effect ablation and gives an antral ablation in the vein, a cone-like ablation, which is excellent. But it's also bipoles, and you can sense near field, so you get sharp electrograms, and you can pace from these electrograms. So once you get a position with the catheter, you then establish a surrogate of contact with pacing around all of the electrodes to see if they all capture, to get a proximity indicator. And then you would ablate, and then in real time, you measure the impedance, and you'd like this to be above, and I'll show this in the case, and that's on the pulse field generator, which I'll explain in a moment. You want that to be above the line in green, and that's a real-time indicator of lesion integrity. And we're working on an index that can help you with that. It's 8.4 French. It's admitted to the left atrium by an 8.5 French. So in the first in-human study, we use the Agilis. It's bidirectional. And above it is the Alepulse PFA generator. And this generator activates the poles in what we call recipes. And you'll see in the case, when I show the film, I activate it with all on, but you can activate it in any sequence. If there's clash, the generator will exclude those electrodes. And you don't have to remove, you can actually just alter the activation sequence so the clash doesn't occur. If there's reconnection in a particular area, you can activate just those electrodes, or if there's poor contact, you can exclude electrodes. To the left of that is the trigger monitor, and in the first in-human study, we gated it to the QRS, but you'll see in the veins I show in the recorded live case, it is asynchronous. We activate for 15 seconds, 25 to 30 trains. So each treatment, it's truly one shot. Once you have position in the vein, you treat, that's 15 seconds, and the protocol for the first in human was 2 treatments, so you do another treatment. There's no movement in between. It's not over the wire. You then go to the next vein and you do 2 more treatments, 15 seconds each, and so on till you complete the veins. This is the patient that you'll see for the recordings of the live case. Fairly standard case, 57-year-old, structurally normal heart, no major comorbidities, on high-dose flecainide and metoprolol and a NOAC, and having weekly paroxysms. So this is the case, and we'll just turn the sound off for the first one. It's my colleague getting access with the Agilis sheath, and it's through that sheath that I'll place the ablation catheter. We've given heparin to run the ACT between 350 and 450, and we've given atropine. These, in the first in human, I did 11 cases and my colleague did 9 of the 36 cases. The first in human ran from January 2023 to December 2023, and we did this case in March 2025. So we hadn't touched the catheter for over a year. It's a very easy learning curve. If you use the variable lasso catheters for mapping, you will easily transition to this catheter. We do a pre-procedure map that is shown here. But what I like about this catheter or this system is it takes all the good things from RF. You can do the map and the pacing in and out, looking at entrance and exit block, and it provides a one-shot PFA treatment. So the good thing about the PFA, and this is the pre-procedure map, we don't need to dwell on this, it's fairly standard. I'll just try and get to the next one. Okay, so this is, we can turn the sound on for this to hear what we say. So this is the pacing, looking to capture from the bipoles. Every bipole. From all of the bipoles. So we have a foot pedal, and pressing this on and pressing it again. You can come up if you need to urgently, but the... This is an ice picture of the catheter. PFA generator will also have safety mechanisms if there's clashing. And Insight mapping is what we used in the first in human, and that's the position. Which would ideally include all the electrodes, but we can exclude electrodes as we design, those that we think that are not in contact, or if there's reconnection in a particular area, we can highlight those electrodes and activate them in any sequence, which is called recipes. But for this one, I'm going to turn all of them on, and I'm going to ablate and turn on now. Ablating. So this is what you see on the ablation, PFA ablation generator. So it's currently ablating, and this is just the first treatment. And at the bottom there is being highlighted the impedances. We can see green on the ablation screen with all of the electrodes, implying that we have good impedance contact as a surrogate. And there we go, there's the first treatment. And we can see all the electrograms are gone. So we've got posterior wall and we've got below the vein, which are areas, new areas we want to cover. This is the left inferior, and I've done 2 treatments of left superior, and this I'll just show this one for another vein, typical treatment. Please? Thank you. So initially pace round. You ready? For contact. This trigger there. Okay, so this is treatment number 3, right about the first treatment in the left inferior pulmonary vein. So again, all on. You can see a picture there on ice. And good impedance contact there, real-time feedback. Impedances are all good, all green. Surrogate of contact, we've done all our pacing. We're capturing from the electrodes that we want to treat. Just tightening up the ice picture there. Excellent impedance contacts, all green. So our surrogates are all very good, and there the signals have gone. Just pace around again from those ones that we're capturing, please, Paul. So after each treatment, we pace around again and see that we have loss of capture. Thanks, Paul. So that's good, nano-capturing. And then I'll just show, this is just to show the lesion set for the posterior wall. Good. And just move that round, Andy, so people can get an impression of what we've done. So move it up and down. And that's good, mate. And even and up and down, yep. And then down, so we can see underneath, good. And then just go all the way around, even though, just so they can see what we've done with the case. So it would have been 5 extra lesions there. And so each of the, outside the vein, you do a single treatment. So each single treatment, 5 single treatments. Post procedure, we do a map, and you can see that you have covered the area that you desire to do for the wide antral circumferential ablation. If there was any areas we're concerned about, we would re-ablate, but this has gone quite well. And we also pace in and out, demonstrating entrance and exit block. So this is just to show the map pre and post and the outcome for this patient. So that's posteriorly, pre and post, with good maps and anteriorly there. And then the catheter positions. So for this case, I did 2 in each vein and then 1 extra for the right sided corona. Now, the RESET AF first in human study, we met all the endpoints. There was a safety endpoint at 30 days for serious adverse events of less than 5%. We achieved this. We had no pulmonary vein stenosis, no transient ischemic attacks, no phrenic nerve or esophageal injury, perforation, tamponade, stroke or death. We did have 1 serious adverse event in the first cohort. We had an acute kidney injury. The patient had baseline moderate renal impairment. They had 2 CT scans with contrast on the day of the procedure. They resolved within 7 days with hydration and gentle diuresis. There was no need for dialysis or hemofiltration. We had a secondary efficacy endpoint that was freedom from recurrent atrial fibrillation at 6 months of greater than 60%, and we achieved this in 34 out of 36 patients, 94%, and a primary efficacy endpoint at 12 months with freedom of atrial fibrillation of greater than 50%, and we achieved this in 32 of 35 patients with 1 loss to follow-up at 92%. All patients were remapped at 3 months, and initially we had very good durability. With the serious adverse event, we did lower the dose and the durability wasn't as good. So we increased the dose and decreased the trains, hydrated the patients. We had no further renal impairment. And in the final cohort, we had 100% durability at 3 months. These are just some interesting cases I'd just like to share with you that we had in the first in human. This is a lady in her 60s who, prior to the procedure, had 2 months of persistent atrial fibrillation, but was paroxysmal before that, on amiodarone, completely troubled by that, quite a comorbid lady. And she had these spinal rods. It doesn't project very well on the x-ray, but these went up behind the atrium. And we did a vein-targeted approach. So I did 8 treatments, so 2 for each vein. And we found afterwards that we had also isolated the posterior wall. And this persisted to 3 months. And this lady's off amiodarone and has had no further atrial fibrillation. And we believe that the PFA may have led to stray capacitive coupling to the metallic implants that have conductive surfaces, thereby producing a more extensive ablation field. And this may have implications for PFA ablation in the ventricle to extend fields, or even in the atrium. It was an interesting finding. We did not see this in any other cases with overlap. They always had some area on the posterior wall. So it was an interesting finding. Another interesting case I just thought I would share with you, a lady in her 40s on amiodarone. She had daily paroxysms of atrial fibrillation. She had a left-sided pneumonectomy for a previous cancer and had ligation of the left superior and left inferior pulmonary veins, which would make an over-the-wire approach very difficult. We were able to do a vein-targeted approach, and you can see the positions of the catheter there in this lady. We had a good acute result, and this persisted to 3 months, and she's off amiodarone and atrial fibrillation free. So in summary, this takes the good things from RFA. I've found it's narrow bore transeptal crossing, things you're used to doing. The catheter is like the circular catheter. We pace in and out. The maps are good, and it's a single shot PFA. So thank you for your attention. Happy to take any questions.
Thank you very much. Very impressive data. So, any question? If I can start again, how did you assess the efficacy? Because the results were quite impressive, like 94% freedom from AF. How did you assess this?
We, at each time point, at 6 months and at 12 months, we performed a Holter monitor for extended periods for a week, and also clinic follow-up and phone contact with patients. So in between times was clinic follow-up and long-term Holter monitoring at the 6 and 12-month mark.
I noticed that you use this map quite extensively to see the positioning. Did you use more, or do you rely more on this map rather than on intracardiac echo, or is it complementary?
It's a very good question. It was very complementary. Intercardiac echo was extremely helpful for catheter position and with getting contact, but the map also was equally helpful. So depends, if you're not used to intracardiac echo, those operators use more the map, but those that liked intracardiac echo relied on it very heavily. And it marries very well. I did show the intracardiac echo. You can see the catheter extremely well. So either way is good. And just plain fluoroscopy was also useful with this catheter because it's similar to the other mapping catheters that we're used to.
This case you presented with these metallic rods is quite interesting. And I did recently also a patient with pulse technology. And I have on the X-ray these metallic rods. So I have to check if there was some isolation of posterior wall. I have to check because that's quite interesting.
It really did surprise us, and it persisted to 3 months. So we think it may be a feature of pulse field ablation that you can extend the ablation field with this, and it may have potential, particularly for, as I said, left ventricle with thicker ventricles, to extend ablation by having something in the right ventricle that potentially can do that.
Any more questions or comments for this talk?
Thank you.
El? Can you give microphone, please?
Thank you, Paul. Great presentation. I have a question. So you have 16 electrodes, right?
Yes.
And so it's all bipolar, right?
Yeah.
It's between neighboring, like, sequential electrodes or cross electrodes?
That's a very good question. So it starts with the odd electrodes being positive and the even electrodes being a negative, then it switches. So it's a whole field effect. So they're simultaneously activated, not in just bipoles. So all positives and all negatives will interact, but the ones that are further away won't be as strong, but the closer ones will be stronger, but they do interact. So it's simultaneous activation.
Right, but the bipolar configuration is between two neighboring electrodes or across loops? So, outer loop to inner loop?
No, next to each other. Not across loop. Sorry, I misunderstood that part.
And
so when you're pacing and you're sensing, yes, is next to each other.
Got it. And did you have any muscle contraction with this?
Occasionally we did see phrenic, but no skeletal muscle, but phrenic nerve activation occasionally, but no skeletal muscle activation.
I see. And how much voltage do you deliver with this?
It's a higher voltage, greater than 2.5 kilovolts.
Yeah, looks promising. Thank you.
Thanks.
Okay, thank you very much again. And the last talk of this morning session will be done by PRAGUE from Sydney, and he will talk about the same technology but using zero fluoro. He's using most of the cases without fluoro, wearing no lead. So we had discussion about that 2 days ago when we met. So we are eager to hear your experience with this technology and zero fluoro.
Thank you very much for the introduction and the invitation to talk today. So I'm based at Westmead Hospital in Sydney and also co-investigator on the same technology. We've been interested in adapting PFA technology to a zero fluoro workflow because we've been zero fluoro for several years. And I think this particular catheter system is quite good for a zero fluoro workflow, and I'll aim to show you a little bit of what we do so you get the flavor of it. The only time we put on lead in the EP lab is when we do an epicardial VT, pretty much. So we often use CARDO, but this is using EnSite. EnSite visualizes this particular catheter better. And we introduce our catheters with an anterior flexion. So sometimes it gets stuck in the groin. There's an iliac to IVC flexion. So you have to flex anteriorly. And you can do that out of the body as well. You flex the catheter first before you put it in, facing upwards, and it usually goes up with no problem. To get our bearings, we go up an AP, and we aim to introduce the catheter into the IVC. If it goes across a PFO, it will go to the right, and if it goes straight up to the SVC, it usually goes straight or slightly to the left of the screen, to the right of the patient. Then we pull down an RAO, an LAO, and we watch to wait to see the catheter flop across the AV into the ventricle. In this position, we do a respiratory gate. So that, for both systems, that's a good, important first step. I didn't show the wire in the SVC, but we put the wire in the SVC and we look at all of this in an AF ablation procedure with TTE because we heard earlier there's some reimbursement problems with ICE. We experienced that in Australia, so we tend to do all of our atrial fibrillation ablation procedures with transesophageal echo, but the ventricular cases I use ICE routinely. So this patient has got relatively small left atrium, a small landing site for the transeptal, and we look at the high to low position of the transeptal needle on the bicable view, it's about 90 to 100. And to work out whether it's anterior or posterior, we go to a 30-degree view or a 50-degree view, and in this case, we want to make sure that it's not too posterior so that we can get into the right side of veins easily. We confirm that the wire, after we've punctured, is going to left superior. So often this 50-degree view or a 20-degree view can get you to see the wire in the left superior pulmonary vein, and then we can cross with our sheath. Now, it can be difficult to work out where the sheath ends and whether you're truly across the transeptal. So what we do is we pull back the dilator. That way we can see a tram track sign. So you see the sheath, you're having tram tracks, look like a railway, and you see the wire that comes out beyond that. So you can see where the end of your sheath is. It's not too far, not too close to the transeptal before you put in your catheter. That's the flushing of the sheath. With Navix, we'd map with, say, a HD grid, but in CARDO, I like to use a pentarray. We don't get any pre-procedural imaging with CT, so all our guidance is based on a good electroanatomical map, and we try to do that without much push-out. Just a little bit about how we introduced the catheter. We chose a 25-millimeter catheter in this case because you can see on imaging and on the map, the left atrium is quite small and the veins are not very big. So the first step is to put this introducing sheath over the proximal bend of the catheter, so we straighten that out. And then you basically uncoil the catheter and straighten it, having it draped over your index finger like a snake, and then you use a two-handed technique to introduce it into the hemostatic valve. In this way, the coil of the catheter is unwound in this double helix catheter, and once you get the tip of it in, the rest of it is pretty easy to insert. So you're just feeding it in like this. And this will fit into an Agilis sheath or a Visigo sheath, so our standard workhorse deflectable long sheaths. So this is our anesthetist playing with 3D TTE, but usually I've already taken the TTE out in a normal case. But for these PFA cases and these new technology cases, I think it's important to use as much imaging as possible to ensure you've got good catheter to tissue contact. And this is an example of us initially placing the catheter into a left superior pulmonary vein. It's in a bit far. You can see, you can appreciate that on the toe. And so we're just pulling it back, getting an antral position. We're looking at the electrograms here, and you see there's good electrograms on a lot of these electrodes, or all of these electrodes. As Paul mentioned earlier, we typically go around pacing the electrode pairs, just making sure that we're circumferentially in contact. Because for a one-shot device, you really got to make that one shot count. It has to really have circumferential contact. So I think everything that you can do to make sure that that's the case is spent, time well spent. Oh, hang on. I should say that there's a tissue proximity indicator actually at the end of this. I should show you. Oh, hang on. That's. I don't think I can show you in that one. Never mind. I'll show you later. So this is the right inferior pulmonary vein. So we've already treated the left superior, and you see that you've got signals here on some of these electrodes, and they are, you can see where they're associated with in this catheter, and it's the bottom part of this vein. So we just need to make sure that the bottom of this left inferior is covered. The carina is already treated, and so we come on to deliver the energy. And you lose the catheter, we shadow it beforehand, and we deliver the 25 pulses asynchronously. I'll show you a little bit later, but Navix has this proximity indicator or a contact index that works similar to the TPI, where it essentially colors the areas that you have ablated if they're close to the FAM that you've created. So this is us now moving over to the right-hand side. So we treated the left side of veins in this patient. And there's quite a bit of splay between the superior and inferior pulmonary vein here. To get flexion, to get good tissue contact, I'm trying to work out where the back of the sheath is. So I push the sheath forward, and you can see that there's a distortion of the catheter because the electrode has gone back into the sheath. And I pull that back, I clock, and I flex the sheath a little bit to get a bit better tissue contact in this carina area. So by inferring where the end of your sheath is, or even though we cannot see it, by feel and on TTE imaging, it's very easy to do this case without any fluoroscopy. This is a good example of the tissue proximity indicator, or the contact index on Navix. It's, again, based on impedance, a blood pool impedance versus tissue impedance with your electrodes, and it will give you a coloration on the map if you're very close to the surface. So here we see that after we've delivered, we have a gap somewhere and connection of the right inferior still, and the indicator suggests that it is a carinal and posterior wall defect. You can see that there are some electrograms here that correspond, 3, 4, 5, 6 are basically carina and posterior carina area, which is a fairly typical place we have to concentrate on. So we deliver further ablations in this area. And this is the contact index, so basically we do another ablation in this area, and here we are closer, so the coloration looks like we should expect to see isolation. And in fact, after this delivery, the right inferior is isolated. So 25 millimeter is it's the smaller catheter. We tend to use the 30 millimeter catheter, but the 25 for a small atrium is useful. And you can also go into the vein. So this map was quickly created with just the 25 millimeter. It's not perfect, but it gives you an idea that you've probably isolated the veins. And so after this, we then remap with the grid catheter. And you can see that we've done a few extra ablations in the carina area on both veins, but 10 PFA shots in total, and we have a good correspondence between the voltage map that we obtain afterwards and this contact index. So it looks like a pretty good antro-isolation. Now, I'll show you a little bit about CARDO integration. So CARDO This is a patient who has got long-standing persistent AF. Actually, she's an elite athlete, and so we couldn't keep her out of atrial fibrillation. This is mapping atrial fibrillation, and her posterior wall has lots of long, interesting signals. So we aim to isolate her posterior wall as well. I'll just draw your attention actually to the fact that this, you can see the Visigo sheath on this. So this is the Visigo, which you can see on the electroanatomical mapping system once you map with the pen array. The catheter is rendered in this first edition in a very unrealistic way. It looks like a really tight coil. It is much larger than that, and we've since improved the visualization of that with some different settings. But for this case, we relied a bit more on the TOE because the catheter rendering was not realistic. So you can see it's got a good position in the left superior pulmonary vein here, and we're delivering the PFA pulses here. And this isolated with one application. We then moved on to the inferior vein, and see it looks all quiet there. And we treated the inferior vein. Then, because I intended to treat the posterior wall, as we came over to the right veins, we blasted the posterior wall on the way. So this is on the right side here. And basically, this is the lesion set afterwards, keeping in mind that the rendering of this catheter is first generation and is not realistic. It's much larger than that, but we make sure that it was good contact with the transesophageal echo. We get a very good posterior wall isolation and pulmonary vein isolation, 1 shot per vein, and only 7 extra shots for the posterior wall, total of 80 minutes, skin-to-skin time, 28 minutes, left atrial dwell time, and 165 seconds ablation time. So a very rapid vein and posterior wall isolation. So I'll conclude with a few remarks that I think fluoroless workflow should not be set aside in the period of PFA. It's got benefits to the operator, to the patient, to the lab in general, because you don't have to wear any lead if you go zero fluoro. And I think we should think about how these technologies can advance and further our own personal preferences for workflow, whatever they are, and explore those that sort of change or in a technical approach to these procedures. This particular catheter is not delivered over a wire, so that's one less thing you have to visualize in a fluoroless workflow. It is fairly easy to maneuver around the left atrium. There are tricks and like with any system, but you can get there fairly easily. It will work with Navix and Cato natively, and there are some Navix will render it beautifully. Cato, you have to set the catheter dimensions correctly to be able to see more realistically what the catheter looks like. It is truly an efficient one-shot system that can isolate the pulmonary veins, and although in the study we did 2 shots per vein as a form of insurance lesion, I think if your contact is good, perhaps you only needed 1 shot, but we would need to learn more about that. The things that will tell you good contact: electrograms circumferentially around the catheter, pace capture, tissue or impedance or proximity indicator, and imaging very critically. I think the imaging is one of the ground truths here. Posterior wall isolation can also be fairly rapid and efficient with this system. So, thank you very much, and I invite questions.
Thank you very much. Any questions or comments? If I may again have comment rather than question, I noticed that you are talking about how to optimize this, circumferential ablation around the left superior vein, for instance. I haven't seen in any of your presentations, for instance, ICE image from the right ventricle, where you can really see the third dimension, where you can optimize sitting on the ridge between appendage and left vein and posteriorly. And that's for us the critical view. And if you use this view, you can really be sure that you are touching both the ridge and posterior wall. So this view is underused heavily, and I was in many places, and they said, oh, we use intracardiac echo, but they use only to see if you are in superior or inferior vein. For me, this is not the proper use of ICE.
Yes.
So.
Yeah, so we don't use ICE at all for atrial fibrillation ablation because of the cost. These patients are on general anesthetic.
This is typical. you say we don't use it because of cost, then you use HD grid for mapping, you use pentarray, octarray.
Yeah,
so
yeah.
you can replace this for intracardiac echo.
That's true, but you get excellent images of the left atrium on transesophageal echo.
I know, you can, you can do.
So there's
different. You can do things in different ways,
There's
but
many ways
you
to
are completely independent. If you have
Yeah.
intracardiac echo, you don't need second operator. You don't need to communicate with another person.
Yeah.
You do what you want. You can check everything.
It's true. It's true. And we do use intracardiac echo for VT ablation, but we can use intracardiac for AF ablation, but I just haven't found it necessary, personally, because the TT imaging is very useful. I've worked with probably 5 to 10 different anaesthetists. They just put a random anaesthetist with me, they're all cardiac trained, and all of them, if you talk to them just in terms of, I want this view, that view, or this degrees, that degrees, show me this, show me that, they know how to get there. So it's because they're used to doing that with their cardiac cases, their open heart valvular cases. So maybe it's a center-specific
It's
phenomenon.
definitely center-specific.
Yeah. So, but I think normally speaking, if it wasn't for a live case, I would probably not use even TTE, just use some of the other indicators. If the catheter is rendered realistically and the mapping is accurate. So with my other RF cases, I just remove the TTE. As soon
Another
as
interesting thing is I noticed that many people do posterior, they say posterior wall isolation. They actually isolate just the belt between veins and never this inferior part, which is, I think, the most critical. If you are above the coronary sinus course and you basically delete all signals there, this is, in my experience, the most important part of this posterior wall isolation, because then typically AFib can terminate, or you can transfer or change into perimitral or a typical flutter.
Yeah.
So I'm curious why people don't use more extensive ablation of inferior wall, because that small part doesn't make any contribution to contraction. So if you destroy that, nothing happens, in my opinion.
Well, I can't speak for other people, but my personal feeling is, so after I do the posterior wall, do pulmonary vein isolation, I always routinely try to induce flutter. And if I induce flutter, I'll go after that with linear ablation. So in that patient I showed with posterior wall isolation on CARDO, after that, we couldn't induce any arrhythmias, so there was no need for me to do further ablation beyond that region. I do worry about mitral annular flutter with very extensive ablation, so I think the posterior wall isolation data is itself not particularly strong, but I think, and I hope with PFA, because it's not done properly,
Until now, we don't have, we did not have technology which can make it, which can make also durable isolation of pulmonary veins.
Exactly.
So all studies from the past, you have to throw away, and you have to redo all studies again.
That's right.
With pulse field technology.
I completely agree. I think we don't find out until we do it properly, right? Whether the intervention works.
Can you give microphone to to the back of this room? Yeah.
I just wanna add some comments on Java's consideration concerning the left posterior wall. There are very few people in the world that is doing just the most inferior posterior portion of the posterior wall of the left atrium. This is very useful just to transform sometimes atrial fibrillation into atrial tachycardia and atrial flutter. And this probably is the reason why we have very conflicting data concerning the concept that posterior wall plays a crucial role, in the treating patients with a persistent atrial fibrillation. So I support and I'm really a believer that portion just below the line that you can produce between the two inferior pulmonary veins, must be done. That is, what I think that. And, we learn from the surgeon. When they do the epicardial ablation, just, they cross exactly at the infra-posterior portion of the left atrium. So this is something that probably we need just to add to our, approach for persistent AF.
Yeah, do you have any feel for the time difference? Does fluoro add time? Not fluoro, zero fluoro, is it a time-consuming pursuit, or is it not?
Yeah, so we looked at this in our own experience because about 7 years ago probably 6 years ago, we transferred from a fluoro assisted, probably 5 minutes of fluoro per case, so low fluoro, to a completely zero fluoro experience. And we found that it took probably about 7 minutes longer to get to the point of getting into the left atrium, because of a little bit of more setup and attention to the right atrial mapping. But the total procedure time was shorter, actually, and I'm not sure why. It could be that we're more efficient because we understand anatomy in 3D. We rely more on 3D imaging. We rely more on TTE or on the mapping or on the signals rather than the fluoro. So, but and we looked at our learning curve. It took about 40 cases.
So 40. I was going to ask. It's 40 cases
for us to stabilize in our procedure time.
And it was actually shorter.
Yeah, it was shorter, and we're not exactly sure why. Someone else has also published their experience in their center, and when they transitioned, and it was also shorter for them for some reason. But this could also be due to the better technologies we have, right? Because say you're comparing in the last few years, a couple of years or whatever with now, look at the mapping catheters that are coming out. Look at the changes in our mapping system and so forth. But I think all of that ends up giving the same message that it's not bad. It's not a big detriment to go to a fluoroless case of workflow, but you have to be willing to give it a go, and you may or may not enjoy it, and it's up to you.
Is there any particular ablation that you think this is a hard zero fluoroless case that is more daunting? I know you said epicardial, but aside from that,
aside from the need to shoot coronaries, then no, actually, I really enjoy not wearing any lead. Play some music, I sit down, everyone has fun. The anaesthetists I work with, love it as well. The
outflow tract, VT, the whole lot. It doesn't daunt you, zero fluoroless.
No, and we used to, at the very, very beginning, we used to use fluoro for pacing leads, but now, I don't worry about it at all. And I've done a PFA in the right atrium with pacing leads, fluorolessly and so forth. There's ways you can use to make sure, keep track
No problem.
of them.
CS leads, the whole lot.
Yeah.
Excellent.
Okay.
Thank you very much.
Excuse me, can I have just one question, please? Very short one.
Sorry, one more question.
Yes.
Sorry, very nice talk. Can you use this catheter for a CTI ablation? And if so, how are you using this catheter? Just selecting the electrodes or?
Yeah, that's a really good question. We have not used it for the CTI yet because we can't in the first-in-man trial, and out of first-in-man trial we've got limited experience. You can select electrodes on this catheter, certainly possible. I've got a lot of experience with Farapulse, as all of you probably have, with doing the CTI. Also, lots of electrodes, right? The problem with it in linear ablation is sometimes you make a lesion much too big for what you want to do. So in this catheter, you can deselect electrodes. You can also ablate in groups of electrodes. So there are provisions to do that, but it has not been fully explored clinically. Or explored all clinically.
I see no reason why it should not be possible, because then you can bend it like if you use flour for CTI with a Farapulse, which is quite effective.
I can't see any reason either. Similar to Farapulse, you can flex the catheter down and do it. It's not specifically designed for that. It's obviously, I think it's not purpose-built, but it definitely would be feasible, similar to Farapulse, but it hasn't been done.
Okay, so...
Thank you very much, Pierre.
No more questions?